Hello, everybody. We're going to go ahead and start the webinar as people trickle in. So welcome all to the 2025 Digital Health Summit brought to you by the California Telehealth Resource Center. We're glad you could join us for today's session, Rural Renaissance Digital Solutions, Revitalizing America's Heartland Against Chronic Disease. As you know, the theme of this year's event is Technology Supercycle Meets Healthcare, leveraging digital health services to combat the chronic disease crisis and other challenges. Before we begin, I'm going to go over a few tips to help you navigate the conference. To start, the session is purely for informational purposes. CTRC has no relevant financial interest or arrangement with any organizations related to commercial products or services discussed during the summit. Next slide. Just a note that you do have to register to join each session. We have, I believe, 2 more after this one. So if you haven't already, I encourage you to register for those, and we will drop a link in the chat to where you can register for the other 2 sessions. The next slide, you can use Zoom functions to ask questions, post comments, and connect with fellow attendees throughout the session. And we strongly encourage you to go ahead and use the chat feature to interact. This session is being recorded and will be posted on the CTRC YouTube channel by the end of the month. If you have any technical issues, reach out to a member of the CTRC team on the platform or contact us at caltrc@ochin.org. We'd also like to thank our funders, the U.S. Department of Health and Human Services and the California State Office of Rural Health for supporting the program and this digital conference. We also would like to acknowledge the contributions of our co-sponsors, the California State Rural Health Association and the Insured the Uninsured Project. With that, I'm going to go ahead and pass it over to Lydia, our moderator for today's session.
Thanks so much, Rebecca. Hi, everyone. My name is Lydia Kotowski, and I am thrilled to be moderating this session with 3 really incredible speakers. We will hold the last few minutes of today's session for Q&A from the audience, but when we hit the Q&A portion, we'll start with a couple moderated questions. Now it is my pleasure to introduce our 3 panelists. First, we are joined by Jeff Dunbar, the CEO of OffSite Care and a board member of the California State Rural Health Association. Next, we are joined by Dr. Martin Entwistle, the Associate Chief Medical Officer and Vice President of Population Health and Ancillary Services at Marshall Medical Center. And our panel is rounded out by Laura Jantos, the founder and CEO of LDJ Consulting and a principal consultant also with Recast Health. So thank you so much to our 3 panelists. I know you have a lot of expertise and insights to share with our attendees. But before I hand it over to you all to kick off the discussion, I just want to set the stage for why we're having this conversation today. If you go to the next slide, please. This discussion couldn't be more timely. Chronic diseases are rising, healthcare costs are climbing, and too often our current systems fail to meet the needs of rural communities and their providers. But there is good news. There is a growing body of evidence that shows that when rapidly innovative technologies that are emerging today are coupled with passionate people in communities across the state of California and across the country, that there are strategies that promise to deliver better outcomes and lower costs. Today, you're going to hear how rural providers are exploring ways to leverage digital tools like telehealth and remote physiological monitoring, as well as AI, to not only manage chronic conditions, but drive sustainable business models. In addition to the work being done in rural areas, the current administration has highlighted technology as a way to address some of healthcare's most pressing problems, particularly in rural communities. These advancements can reshape the way care is delivered across California. And with that, Jeff, I'm going to hand it off to you to get us started.
Thank you, Lydia. So I thought I'd give a few examples of service lines and programs that we have throughout California and rural sites, give you a flavor of how we deal with chronic diseases in our everyday programs. So a few examples on the critical care side, which is really how we started. On the critical access hospitals, those that are 25 or less and meet certain geographic requirements, we're often the only physician in the hospital at night, albeit remote, other than the ED physician. And so pretty much any patient that is admitted with chronic diseases is seen by our critical care specialists. And and they're often in these places, being admitted with several comorbidities. If they weren't seen by intensivists via telemedicine, that would mean a long car ride via ambulance or a helicopter ride or a fixed wing trip to a tertiary center to get the care they need. And so digital health is a way to treat those patients and their existing comorbidities, chronic diseases that we can consult with other specialists to treat. And rural hospitals, regardless of the size, also have challenges. Here, it's mostly about economics. And so using digital health or telemedicine, a facility can provide high-level quality care for often a third to two-thirds the cost of in-person care. Even more so when you start looking at the hospitals that are hiring locums to fill some of those needs. Now with the long-term acute care hospitals, LTACs, here our intensivists, we're also pulmonologists, see the sickest of the sick. Sadly, it's often their last stop before end of life, and no place has more refractory chronic diseases, illnesses than long-term acute care hospitals. Telemedicine can often bring subspecialists to the LTACs, of which there's very few in the country, sorely needed. And where they're located often determines what kind of subspecialty care they get locally. And so having the availability of a specialist via telehealth is really important. I would say respiratory failure overall is the biggest reason people are admitted. Often underlying intrinsic lung disease, COPD, is why patients receive a tracheostomy. Chronic respiratory failure due to COPD, congestive heart failure, pneumonia, and lung cancer is the most chronic issues that we address. And then large rural hospitals, even though they have size, they often have some of the same issues in rural that the smaller hospitals have. And to give an example, we have a cardiology program in the Central Valley. And this service provides an opportunity for patients to be seen locally. In the past, EMS bypassed the hospital an hour north or south in the tune of 350 to 400 patients a month. And so you can imagine what that means to the hospital's bottom line if they're now able to be seen by a specialist via digital health. And here, maybe most of these patients also have chronic diseases like diabetes, chronic renal failure. Many of them are on dialysis. Morbid obesity is also a main comorbidity. Most of the time, these are low economic agricultural workers and their families. And so having the availability of a specialist who can also consult with other specialists, subspecialists for this is a real benefit. Infectious disease in a small rural hospital is, in our case, one example, more about education than it is about the actual consultation. Here, we're really, our specialists are helping to prevent resistance, antibiotic resistance. They see a lot of diabetic ulcers and a lot of soft tissue diseases. And prior to us coming in with telehealth, they would have a 2-week IV antibiotic treatment. And so we're coming in and helping them to use oral versus IV, limiting broad spectrum use, reducing that 2-week standard, and sort of busting the myth of antimicrobials just because a patient is admitted to a hospital. And as these chronic patients present on a recurring basis, we just want to create an environment where there's not antibiotic resistance. And then our hospitalist service has sort of evolved. Used to be mostly real-time audio video consultation, admitting patients at night and following them throughout the night until the on-site hospitalist came on board in the morning. That has morphed into more of a telephone service. And what it allows a hospital to do, rural hospitals and urban alike, is to reduce the FTEs needed during the evening. So during the day, it might be totally appropriate for them to have several full-time employees on the hospitalist side to treat new admissions and treat all the patients on the floor. But at night, it might only require 1.5 FTEs. And so having a full-time on-site hospitalist treat new admissions and having the telemedicine via phone and the use of the EMR treat all the patients on the floor, basically, phone calls that aren't really billable events. One, because you're not using audio and video, but also they're just, quick consults. Not something that is a billable encounter. And so those are just some of the examples that how telemedicine can be used in order to treat chronic diseases, for us right now throughout California.
That's wonderful. Thank you so much for sharing what offsite care is doing and the spectrum of ways digital health can be used. We're going to pass it over to Martin now to share what Marshall Medical Center is doing and where it's headed.
Well, thanks, Lydia. Just give people a context for Marshall Medical Center. We're located in Placerville to the east of Sacramento, right at the start of the Sierra foothills. We serve the western slope of the Sierra Nevada in El Dorado County. That's a population of about 165,000. Interestingly, we're at this border between a somewhat suburban population and really quite a rural population. If you look on the map, a straight line distance is not necessarily that great for folk, but the nature of the geography means it's really challenging to move around as you cross the big river canyons, etc. So rural isolation is a big issue. We also have a population skewed elderly and all the challenges that brings, along with that fierce independence of people that choose to live in rural California. So a little bit of insight into some of our experiences. Currently, in terms of telehealth, our focus has largely been on inpatient management. We extensively use telepsych, ICU neurology, ID for the management of our patients. And that's similar to Jeff's experience, the challenges in finding specialists, particularly in those narrower fields, and the ability to staff the hospital. A big focus for us is to really try and keep our patients in the community and care for them in our hospital, in our clinics, etc. And so the ability to provide that support reduces the need to transfer out. And for those of you working across the area, I'm sure you face a similar experience that transfers are extremely challenging. So the ability to keep patients is really important. We have tele-NICU to support our birthing center. And overall, that enables us to provide 24/7 care in the community for critical services. Just moving to our past experience, we had a greater use of community clinic-based teleservices during COVID. We expanded that up for obvious reasons, and I'm sure other people were doing the same. And if I'm honest, we probably missed an opportunity not to keep that going post-COVID. We had a focus on bringing patients back into the clinic so that we could reconnect with them and re-engage with their care. And we put a lot of emphasis onto that. And so it feels that we've been a little behind the 8 ball in terms of our use of both teleservices and remote patient management. And that's even in the face of us having some pretty advanced and fairly successful shared savings ACO type programs with a focus on preventative care. However, we recognize the need to be focusing on teleservices and remote patient management. And in the last couple of years, we've challenged ourselves to expand that into our rural community. And we conducted a small pilot program in our Georgetown area. We have a rural health center up there. And that's typical of our rural communities, with people being fiercely independent, somewhat older, but with all the issues of chronic conditions, behavioral health, etc. Our focus in that program, based on a past experience, was could we even deploy technology into people's homes? So rather than focusing on what can we do with the technology, recognize the barriers. Can you get people to adopt? So we used Android tablets, and the aim was to be able to deploy them, get people to keep them in the home and use them over. Our target was actually only just a month. It was really a short program, although for many people it extended to 3 months. And could we connect them using those tablets, looking at their social determinants of health, their social needs, such as I've got an upcoming appointment, but I have no transport, I have no gas for my truck. Or I'm about to run out of my meds, and again, I have no way to get them. So aiming to be engaging and preemptive in how we provided services and connect them to their local clinic, as opposed to them waiting till they have a crisis and then coming some distance at some risk to get to the hospital, to get to the emergency department. That proved reasonably successful, small scale though it was. And so moving to our current strategies, our aim is to rapidly expand teleservices and remote patient management, particularly to our rural community. So on the teleservices, we're very keen to make better use of availability for consults from the clinic to the patients locally, so we can expand access and expand hours of availability. We're very interested in doing similar for the specialist services, areas that it's challenging to get a local outpatient consult, so neurology, dermatology, infectious disease, ongoing management, etc. And so we're interested in the use of either patient to specialist or peer-to-peer telehealth to provide expanded access to care for patients with specialist needs within our own community. And then similarly expanding up that project that I mentioned to deploy more widely the use of tele and remote patient management in rural communities to connect with the patients. And now we want to introduce monitoring of patients, so diabetes, blood pressure, the usual suspects, to do what everyone else will be working on too, which is to be preemptive, understanding the individual that is maybe not doing so well, that we can be proactive in outreaching to provide care, again, to avoid an admission, an ED visit, etc. So those are our big areas for focus. On the challenge side, we still face the typical challenges of deployment of technology in rural areas, connectivity. We're working with the local county that's got an initiative on to expand broadband into rural communities. That's extremely helpful. We've got the issues of remoteness geographically for support, and still the issues of, I'm calling it intrusion, the suspicion that the deployment of a black box into your home is going to be surveilling, etc., and the concerns. So a lot of thought went into that pilot I mentioned, is how do you market? How do you gain trust? How do you get people to be willing to have the technology that you can then do things with? We also face the challenges of the cost of technical program support, even the availability of people to do that, particularly if they may need to travel around. We face some challenges still with providers preferring to do face-to-face visits than to do remote care. So we have to work on that and help them understand how that can still be satisfying work and extremely important to their patients. And then, of course, the elephant in the room is financial sustainability. That includes the challenges of site of service, agreement on that, where you can provide services from. There are barriers in that, or potential barriers may come back if waivers, etc., get removed. And then just making it financially viable. because right now it's not. We have to invest in that, and that's obviously a challenge, and it's another driver as to why you might be trying to bring patients back into the clinic when you could be managing them remotely. So, Lydia, that's an overview of our experience and what we're doing, some of the challenges that we're working to address.
That's wonderful. And thank you so much for sharing sort of where you are and where you hope to go and what needs to be overcome to get there. I'm sure many of our attendees are facing similar challenges and have similar aspirations for the future. And so to round us out with sort of our introductory materials, I'm going to hand it over to Laura, who's going to provide a patient perspective on digital health.
Thanks, Lydia. So when we think about digital health adoption and how do we measure the success, so I see the question in chat about fixed and variable cost drivers and settings. Typically, the KPIs or key performance indicators that we have available in our systems aren't necessarily the best ones that we could use to measure and monitor. So looking at, for example, patient portal adoption as a measure of success really isn't the end all be all. Think about the fact that those systems really are fairly transactional. They might help you with staff for check-in or improve your revenue cycle. But from a patient perspective, they really don't give me what I need to manage my care between encounters. Often the information isn't correct. There's a concern now that maybe if I mess with my provider too much, I might be charged. Recall information in there can be really inconsistent. Do I come in for my mammo every 2 years or every 1 year? It's really unclear. And they're not in every language also, so it's hard to make them super accessible to folks. The other thing that we tend to see as an indicator of performance are Press Ganey surveys, and I don't know if anyone's taken one of those lately. I took one this week, and it asked me if I had called my clinic lately for to discuss lab results, or if anyone had called me to discuss lab results. I mean, some of the information in these surveys is really outdated, so our modes and our methods need to be updated to align to really using digital technology. So next slide. By way of example, I'm a TBI survivor, a brain injury survivor. I've had a couple of them. My most recent one, I lost a lot of progress and I got so angry that I tracked everything that had happened to me. So this is just to give you a sense that to find a provider, even though I had been very clued into that whole setting, took me over 11 referrals to find my core team of 3 providers. I had over 100 appointments in my first year of recovery. My cognitive capability was down to 45 minutes twice a day. And all of the time I spent simply trying to pursue my own healthcare for my recovery took up more than 50% of my actual cognitive available time. So when we think about digital health and the opportunity that gives us, whether we're in a rural community, whether our TBI is now a chronic condition, so what kind of chronic condition we have, there is a huge opportunity to help people access care in their homes and measure and monitor that care so that they can be more engaged in it in their own improvement of outcomes. Next slide. So when we think again from the patient perspective, some of the key metrics are, when you're diagnosed with something, it's just incredibly overwhelming. You don't really understand what this thing is. You don't know what you're supposed to do. You don't know who can treat you. You don't know how you're supposed to get better, what your potential outcome is, what this is going to cost you. As you're going through the process, you don't really know what's normal and what's not normal. Are your bills correct and accurate? Are you supposed to be paying what you're paying? And then we also have in our current environment, there are a lot of complementary services around your traditional direct patient provider relationship where you might get a call or an email or something from some service and really not have an idea of what that is and what they're doing with their information. Back to what Martin was saying about how do we, we're entering people's homes digitally and how are we really thinking about encouraging that relationship with folks. So there are a lot of potential touch points there, but we have to really think about this from the patient perspective and make sure we do it in a meaningful way. So a better way to think about some of this stuff is, do patients have an understanding of what was discussed? Do they have actionable information that they can take with them between encounters? Are we getting information through our multiple modalities of telehealth, remote patient monitoring, RTM, e-consults, all of these modalities, are we helping them ensure that they can get the high quality care that they need to have locally without having to travel large distance, reducing their time and effort in the process, making their costs more transparent to them, and helping them have a voice in the care process. So I think I'll leave that, Lydia, and then open the rest of the discussion.
Absolutely. Thank you for providing the patient perspective, which is so important to any consideration about a change in how healthcare is delivered and accessed. Delivery changes need to work both for providers and for patients. So it's great to have sort of all sides of that equation represented in this conversation. So we're going to get started with some questions, and starting out with sort of a hopeful question. You all just laid out a great foundation for where digital health is currently, how it could be used, how it is being used. Where do you see the biggest opportunities for continued growth or continued adoption, particularly across rural communities? And whoever wants to kick us off is welcome to get started.
I think a great opportunity, and this is not my field of expertise, but wearables have become so ubiquitous and for the most part inexpensive that new developments for RPM and RTM is exciting, and it can help exploit the relationship between the two that are seen in many patients with chronic diseases. For example, chronic disease patients experience stress at like 68%, and over half, 57%, have anxiety. So that's more of an RTM indicator, but it's something that an RPM patient's physician can pick up, right? And so if they're on, clinics can't bill for both, but if they're on one, they might identify a patient for another. And there's new billing codes coming out. So 98975 through 81 make this attractive to rural clinics and FQHCs because they're getting rid of the global HCPCS. Did I say that right? The Geo 511, which is a global billing modality. You can get more specific into the actual treatments that the patients are having. That's effective July 1. And what's really cool about that is that the NPPs, the non-physician providers, can bill for those services. So NPs, PAs, PTs, OTs, SLPs, and that makes it more attractive to the clinics. And just a couple things, because I've done some research in this, as involved as a consultant in some stuff. There's an organization, One AI Health, that in conjunction with the Michigan Stroke Network did some studies on the use of RPM wearables, and they reduced readmissions for stroke patients by 71%. And the University of Pittsburgh Medical Center followed CHF patients and reduced those readmissions by 76%. And 80% of all hospital readmissions come from chronic disease patients. So here's where I see a real opportunity.
Thank you so much for sharing and for bringing in some of that billing and coding information, which is so critical to sustainability of any of these models. Laura or Martin, do you have anything you want to add?
Yeah, Lydia, very similar to what Jeff was just saying towards the end there. I think the biggest opportunity is, given that the general behavior of people living in rural communities is to present late for a whole variety of reasons, some of which we've touched on, but it is a fact. I'm generalizing, so I apologize for that. But for those individuals, how can we engage better so that we can understand and support them to get access to care sooner, that can prevent some of the complications that lead to an admission or an ED visit, would help them, support them in their day-to-day lives to be in the community and not have to come out to seek care. So I think those are some of the big opportunities, and the challenges are the ones that we've touched on in the presentation. Is how do you get people to trust that? How do you get people to see that that has a positive value, not it's a negative intrusion. Those are the opportunities I see, supporting people to be healthy and well in the community to the extent that's possible.
Absolutely. At the end of the day, keeping people healthy is what it's all about.
The
We
one
can
thing
move.
I'd like to add, Lydia, really quickly is that the two things from drawing on some of the earlier discussions, AI is everywhere, and the cat's out of the bag on that, right? And if you're at home and something seems weird, you're going to go online and you're going to look it up, and there's going to be some AI in the background that's going to help you with some initial, do I need to go see somebody? How bad is this type of a question that's going to compel you, hopefully, to go see someone if that is the case. The other thing is that if we look at what's going on across the ecosystem, almost everything is a healthcare system now. Every company has some sort of a healthcare component to it, whether it's large organizations that have huge AI funding behind them, or any other thing that you're doing and you're interacting with. It's got some sort of a health component to it. Hopefully, helping us stay at home and live better, happier, and healthier lives, but needing that guidance from clinical professionals, hopefully in the local community. So I'm hoping that the AI and all these advancements are going to help with local diagnostics and make local communities stronger in their capabilities, and be able to rely on e-consults from centers when appropriate, or even use some of their excess capacity to support each other in rural communities more effectively.
Absolutely. And in an earlier session today, we heard just the importance of making sure rural providers and patients are involved in the development of these AI tools to make sure that things are representative and to make sure that they are suited to their conditions and sites of deployment. So you're right, AI is here, and we got to make sure everyone is involved in that. So moving to our next question, and we definitely are concerned about ROI and quantifying the value of these kinds of investments. Some digital health has been around for a while. Some of it, like certain AI-enabled systems, are much newer. So when you're thinking about how do you quantify or model return on investment for standing up these services or business lines in rural hospitals, what are the key considerations? How can you make that business case? And Laura, we can start with you.
Thanks, Lydia. Sure. I mean, we can look at AI agents to reduce charting time, to collect information in the visit, to make visit summaries clearer to patients. We can look at improvements in coding and reimbursement. We can look at expanding our coverage through virtual visits, expanding our specialty coverage through virtual visits and e-consults, with reimbursement in the background by, looking at factors, how many encounters do you have, availability, programs you're trying to develop, et cetera. Additional revenue from telehealth, as well as RPM and RTM, and Jeff's probably better at looking at the economics on this than I am, but looking at shared savings opportunities too, to reduce readmissions, et cetera, with some of those efforts.
Thank you so much. Yeah, those are great considerations for sure to be considering. Jeff, Martin, anything you want to add?
Yeah, it's interesting. If we look at the ROI right now, you probably wouldn't do it. From our perspective, it doesn't really pencil out. And that's maybe how we got into the situation where we returned to doing face-to-face visits. So I don't know that always taking a reductionist approach in terms of an ROI or a numerate approach is the only approach to take. I mean, we're being driven right now by strategically, it's the right thing to do for the reasons we said. It's about delivering care and meeting our mission. And we need to do this. And to some extent, an article of faith that it will get sorted out sometime soon in terms of that sustainability. But that is an article of faith, and that's the risk and that's the concern, that we don't get there. And so we end up having to continue to invest over many years in order to do the right thing. That's a worry. I'll just make a comment that actually answers one of the questions in the chat from Anu. How do you deal with patients not able to take advantage of telemedicine but go to ER and hospitals? So a factor in that ROI may be, do we rely on individuals to bring their own devices? So Laura was just touching on that. So they use a device, their phone, and they use wearables that they purchase. Well, the challenge in that is that then you can't necessarily control it. You're dependent on people being willing to have them and use them. The alternative is you do what we did in our pilot project, which is you put the devices in place. So you control that part of the technical ecosystem, but then that's got an overhead because it may not be reimbursable. The individual probably isn't going to pay for it. And so you increase the cost of your deployment. So the ROI is complicated depending on what approach you take. And that may depend on the location you're in and what's possible. But that's an important consideration. We deploy technology to address the issue that Anu's bringing up, but that has a big sustainability challenge to it.
Yeah,
I know
thank
it's excellent on the clinic side, but from a hospital standpoint, one of the things on the ROI is you just need to get hospital administrators or clinic department heads to see digital health, or in my case, telemedicine, not as another cost center, but an opportunity to grow the bottom line. I'll just give you a brief example. Our first customer, actually, and longest, at Howard Memorial Hospital in Willits, California, very remote, very rural. But they have an orthopedic surgery group that makes that hospital the most lucrative of the 5 Adventist hospitals in the region. They would not do those surgeries at that hospital if they didn't have ICU backup. ICUs are usually not a moneymaker in, especially in a rural hospital. But the fact that they have, high quality telemedicine ICU backup, they're willing to do those surgeries in that location. And so finding ways to, improve the bottom line through telehealth is viewed from a different lens can be helpful.
Thank you. Yeah, but all of you provided great nuanced perspectives to show sort of the creative thinking that can go into what is the return and why are we doing this. So thank you for sharing all those perspectives. I see we have a question in the chat. How can hospitals educate patients not to utilize hospitals when their primary care provider can handle most of their clinical needs? So how can we use some of those digital health tools to keep people in the right place for their care?
You have to really take a hands-on approach. And I don't know if anyone else is in the position of being the family password resetter or appointment accompanier to do the interpretation, but that seems to be a lot of my role these days in life. And I think, especially in our rural communities, we take care of our friends and our neighbors. These are people that we know and we care about. We have to have a very hands-on approach when somebody's coming in to be able to say, hey, let's download some stuff for you. Let's look at, how we're going to use our blood pressure cuff when we go home. Let's kind of do some health education stuff while we're here, and then doing the follow-up call or follow-up telehealth visit to kind of reinforce that behavior and reach out. I think it has to be a pretty hands-on process. I'm hopeful that and I am aware of an awful lot of development that's out there that hopefully will integrate nicely for people and be accessible to be able to remind them of what they need to do and help direct them to appropriate venues. But, like Martin said, I think folks in rural communities tend to wait till the last minute to come into something really is kind of big. And so there is going to still be hospital utilization. You have to just take advantage of that time appropriately to coach and direct.
Yeah, adding to that, so in the pilot project I outlined, a lot of that was about building trust. We deliberately had the site of service be their local RHC, and a lot of it was video connectivity. So we were trying to build a relationship between the individual and the clinic staff. So it was a personal thing. It wasn't just a process. And in that way, they could, one, build trust with an individual. They could see that the local team could actually help them and help them with things that mattered to them, such as I need my med refill or I need to get to a clinic appointment. We deliberately didn't necessarily focus on the clinical things that are of interest to us. What would be of value to you, to see if we can get people to engage? So I think it's trust, engagement, and you've got to be patient and persistent.
Yeah, and
Absolutely.
I'd like to just add that, I mean, if I had one wish, I would really want for the systems to be designed more from the patient perspective so that they do make engaging for patients much easier. So patients can have some transparency. Even when we were talking earlier today about e-consults and thinking about how great it is to be able to get a specialist um, advising a primary care physician so that they can provide a broader scope of care more effectively. Having a patient understand that, getting that information back to the patient is critically important. And I think we continue to have to work on developing systems, interoperability, and transparency in the process.
Absolutely. And I think that is a wonderful note to wrap up on, keeping the patient's center of everything done in healthcare and really focusing on, as Martin put it, building that trust. There can be a lot of scary things when it comes to healthcare. So building trust between patients and providers is so critical. So thank you to all of our wonderful speakers for participating in this panel. I personally learned a lot. I'm sure our attendees learned a lot as well. And I'm going to hand it over to Rebecca, who's going to close us out with some final housekeeping items.
Thank you all. That was a very interesting session. And again, I think just hearing all the different perspectives was really helpful for me as well. So I want to thank all of our speakers for joining us for this great session. And we have up here a survey. If you could go ahead and launch the survey just to get some feedback from the attendees on the session. We would love to hear from you if this met your expectations, if there are any other needs that you might have, any ideas. The survey is a great way to do that. So we'll go ahead and launch that during this wrap-up time so you can have a minute to fill it out before we wrap up, before we close out the session. So other than that, I wanted to mention that we do have some ongoing support that you can access. I'm not seeing the survey, but maybe that's just me. Oh, okay, I see it now. So hopefully everyone else can see it as well. All right, let me just go back to our slide, the ongoing support slide. Just wanted to let you all know that you can find more information on our website, caltrc.org. We have other events, webinars, on-demand resources, and more. You can also always reach out to us at caltrc@ochin.org. And the next slide is about our upcoming events. We have our AI Bootcamp that we are co-hosting. It's the first healthcare AI Bootcamp with a virtual and hybrid sessions happening from June through August. So if any of this is kind of sparking some interest from you about learning more about AI, I highly encourage you to register for that. Registration will open on June 1st, and at that point you'll be able to click on the link in the slide and you'll see the registration link. And we can also drop that in the chat. And the next slide is about our newsletter. You can stay in the know and subscribe to our monthly newsletter to receive the latest updates on available trainings, webinars, and on-demand resources. So highly encourage everyone to sign up for that as well. And we are getting some survey results in already, so thank you all so much for filling that out. We will go ahead and wrap up this session, but please we'll leave it open for a minute or two to let anyone else fill out the rest of the survey, but just want to thank our speakers again and Lydia, and we will go ahead and close it out there. Thank you all.